Go ahead.
Nocturnal paroxysmal dyspnea.
It actually should be paroxysmal nocturnal dyspnea.
Okay.
The paroxysmal just means that it happened very quickly, and the nocturnal means it happened at night, that they woke up short of breath. So that's what that is. And you may see it as P as in Paul, N as in Nancy, D as in David. So those are some things that you can look at. Okay. So you give somebody is on captopril. So besides heart failure, what's another exemplar that we're studying that captopril can be used for?
Hypertension.
Hypertension. What's a side effect of taking an antihypertensive med?
Nagging cough.
Okay. What else?
Orthostatic hypertension.
So basically, those ACE inhibitors, the patient's going to get dizzy. Their pressure can drop very quickly with quick movements. So if they just pop up out of bed, so they're laying down, oh, they get up, right? Then they may get really dizzy and their pressure may drop. So what kind of teaching would you do?
Just sit on the side of the bed until you don't feel dizzy, and then get up slowly.
So basically, you're gonna change position slowly to make sure you don't get dizzy and then fall. And that should be one of the things that when you are talking to your patients and giving them those morning medications, you're giving them those ACE inhibitors or calcium channel blockers or any of them. Those are the things you want to say to them. Make sure that if you're getting up or you want to sit up, that you do it very methodically and slowly, that you just don't pop up and spring up and hop up out of bed, because that quickness can actually cause your blood pressure to drop, and then you may get dizzy and then you're going to fall, and now we have another problem. Okay. What medication do we use in angina? Nitroglycerin. What's the side effect of nitroglycerin?
Pounding headache.
So they can have a headache, for sure. So our job is basically to tell patients you can develop a headache. That's normal. So it's not an adverse effect. But the headache is common because what is the nitro doing?
Vasodilation.
It's causing vasodilation. So that vasodilation effects of the medication is what's causing them to actually, potentially have the headache. So tell me some risk factors that you would see related to coronary artery disease. Like, what would be some risk factors of them developing coronary artery disease?
Stroke.
Not stroke. Risk factors of developing CAD. Now, stroke will be a complication. I will give you that.
Sleep apnea.
Okay, so sleep apnea, I go with that. And you'll see most people that have sleep apnea are what?
Obese.
They're obese. So obesity would be one. What else?
Hypertension.
High blood pressure. Okay, I can get with that.
Smoking.
So what specifically about the smoking? The tobacco?
Probably the nicotine.
It's the nicotine, because the nicotine causes vasoconstriction or dilation?
Dilation. Constriction.
Constriction. So what other things? So think about things that clog the artery or that would prevent blood flow.
Arteriosclerosis.
Okay, so atherosclerosis. What about diabetes? Would that do the same?
Yes.
Yep, diabetes would be also a risk factor that would, cause perfusion to be diminished and lead to coronary artery disease. Okay, so let's see what else. So you have a patient that has heart failure. They have an advance directive that says they do not want to be on a ventilator, but they want to be kept comfortable.
Right.
So now the patient's having shortness of breath. What do you do?
Ask for an order for oxygen.
Do we need an order for oxygen?
Comfort measures first.
Okay, like what?
Just raise the bed, head up the bed.
Okay. But if they're short of breath, are we not going to do something about that?
We're going to give them oxygen.
We're going to give them the oxygen. So although a patient may have an advanced directive and, just because they don't want to be on a ventilator, it doesn't mean that we don't give them oxygen. So we give them oxygen up until not putting them on a ventilator. So they can do even up to a BVM. So make sure you understand that your do not resuscitate is not a do not treat. If they're not in a resuscitative state, which would be apneic and pulseless, right?
Right.
Then we need to treat them and do what we call supportive care. So we treat the signs and symptoms. Because if you're not treating the signs and symptoms, then you're basically just, helping you're letting the patient die is what that boils down to.
So you don't need an order for oxygen?
If your patient's struggling, you can put them on oxygen.
Oh.
So more than likely, if you have a person with heart failure, they're going to be on oxygen already.
Constantly.
So, you have some prudent nursing judgment that you can utilize. It would be no different than if you were giving, the patient started experiencing some ototoxicity, like tinnitus, ringing in the ears from Lasix being pushed too fast. Then, you can't do anything about the push part, but you can definitely stop it. So you can't do anything about what's already entered, but you don't have to put any more in. Does that make sense?
Yeah.
Or if somebody has an allergic reaction to blood products, you would stop that immediately, right? Exactly. So you have some leeway. Now, if you're not coming up and writing an order for oxygen, but most of these folks are already on oxygen. So we would basically, give them the oxygen. And you can tell your physician, I place the patients on 2 to 4 liters of, 2 liters of oxygen to see if this would help them breathe better. Most physicians are not going to be like, why'd you do that? Most of them won't do that. So if you have someone in left heart failure, what medication would you give to decrease excess volume?
Lasix.
We can give and what kind of medicine is Lasix?
Diuretic.
It's a diuretic. Okay. So your patient has just been diagnosed with heart failure. So they've never had it before. They had some heart issues or coronary artery disease, and now they are diagnosed or just been diagnosed with heart failure. So what concerns, when do you want them to kind of come back in? What kind of patient teaching would you do related to that?
To come back into the doctor's office?
Right.
Every 2 weeks. Okay.
Do they have to come in every 2 weeks, or should they come in if they start noticing some changes? And then if that's your choice, then what changes would you be speaking about?
Weight gain.
Weight gain. So patients that are just newly diagnosed with heart failure or have heart failure, what you really want to talk to them about is them not having so much increase in weight, like in pounds. So if they have, say for instance, 3 pounds, they gain 3 pounds in 2 days. Is that a lot of weight?
Yeah.
Because isn't 1 pound like a liter of fluid?
Yeah.
Okay.
I think
So,
didn't you say something about 2 pounds, no more than 2 pounds per day, you got to call the doctor right away?
Right. So 3 pounds in 2 days, that'd be 1 pound too many, correct?
Yes.
But how about a week? If they're, gaining 3 to 5 pounds in a week, that's too much. That's like 6 liters.
Yeah.
So, you want to talk to them about, weight gain. So if they gain weight and say it's, 7 pounds, would that be alarming?
Yes.
Absolutely. If it was 5 pounds, that would still be alarming, because we're talking anything between 3 and 5 pounds in a week, or 3 pounds in 2 days, or, more than 2 pounds a day. Then that's a lot of fluid that they're intaking, and they don't really have, it's going to really fill up in their lungs, because there's fluid also in the alveoli, but there's also the alveoli are inflamed. So now you really can't, your gas exchange process is really, really low. Let's see. There's something else I want to.
We would definitely teach them low sodium.
No ramen noodles, no
Yeah.
canned soups, no. What about deli meats? Would deli meats be good?
No.
Nope, deli meats would not be good. So let's make sure we understand that, because that's a lot of salt, all the curing and all that they do. Okay, so you have somebody that's in acute respiratory distress. The monitor keeps beeping, 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 beep, beep, beep. You've been on the floor and the monitor's beeping and the nurse is wherever. The patient gets mad. Do they not? Why are they upset?
The beeping noise.
What is the beeping preventing them from doing?
Sleeping, resting.
Exactly. And unfortunately, I tell people, this is not the Four Seasons. There's going to be a lot of movement in and out. We'll try to minimize it as much as possible, and cluster care and things of that nature. So how can we, if we have that going on, what are some things we can do? How can we help them not hear the pump?
Make sure that it's not kinked. Make sure the IV side is patent.
Mm-hmm.
Do not turn the alarm off.
Correct.
Tell them that it could go off when it's empty. You'll come back every so often to check on it to make sure it's not going off.
So even if, what else can we do? So if they're hearing it, what can we do to prevent them from hearing it?
Headphones?
Headphones or earplugs. So we can offer those to help decrease the amount of noise from the monitors, and then kind of provide a room that's, with privacy and the mood, with the lighting, making it dim and things of that nature. So, ask the patient how dark they want it, how light they want it, but that's, something that you can work out with the patient. All right. Let's see. I thought that was my place. I was like, I never heard that before. I think somebody's smoke alarm is bonging. I think I covered everything I wanted to talk about in relation to coronary art, or in relation to CAD. If you give somebody a diuretic, what electrolyte you want to monitor for?
Potassium.
Potassium. What are some lifestyle changes we could recommend for patients with diabetes that have coronary artery disease? Well, they don't have it, but they may be at risk for it. What are some things we can tell them to do?
Weight loss.
Weight loss, okay.
Exercise.
Exercise.
Heart healthy diet.
Heart healthy diet. So basically incorporate having healthier lifestyle choices. So eating better, more fruits, more vegetables, and more leaner meats. Those would be some things that we want to talk to them about, so that they do not develop diabetes. Now, it could be genetic. So, it may not matter what you do. It may not necessarily work, but at least you have that. So what type of folks are at risk for high blood pressure?
Ethnic people
Okay.
who eat greasy foods.
African American.
Okay.
Sedentary lifestyle.
Okay. So people that have like heart failure, renal failure, stroke, we want to try to identify that. But the folks that are at the highest risk are older people, African Americans, patients with diabetes. So those would be your people at the highest risk. Okay. So you have a patient that has heart failure, but they haven't put out that much pee. Their urinary output has been like 20 milliliters per hour. So how can you increase urinary output? What can they do?
Increase their fluid intake.
They can increase their fluid intake or give them like a fluid challenge or something like that. You know, that may be an option of what they can do to help increase fluid. And when I'm talking about a fluid challenge, am I talking about a liter of fluid?
No.
So I'm talking about a half a liter or 250 milliliters. That would be like a fluid challenge. The lower number would be for your heart failure patients, so you don't put too much fluid on their heart and cause them to, you know, have more additional problems. So those are things that we want to make sure that we're looking at. So tell me, what are signs and symptoms of venous insufficiency?
Venous.
So we know arterial, because
you're going to have lower extremity edema.
okay.
You could get those sores that are not, they're shallow, and
Are you talking about the pigmentation?
yeah, on the lower extremities.
Yeah, so that they get pigmentation, they can have dermatitis, edema.
They're going to have warm lower extremities.
Okay.
Warm to
Because
the
if it was arterial, the foot would be what?
cold.
It'd be cold. So that's true.
I guess the edema would happen at nighttime, though, wouldn't it?
Over time, they would start having a collection of fluid. So they would have less of the problems in the morning and more of it during the evening as time has gone through the day, and you know they're up moving around, drinking, et cetera, et cetera.
And I read somewhere where if it's venous, you want to elevate the extremities above the heart, and if it's arterial, you want to dangle.
Correct. I keep looking to the right because I keep hearing a bunch of water. It's like pouring outside. All right, so since we're talking about CAD, let's talk a little bit about pregnancy-induced hypertension. So preeclampsia. When someone is has, you know, a significant bout of preeclampsia, what lab value would be extremely significant to look for or to monitor?
Creatinine.
Protein in the urine.
Okay. That's abnormal, for sure. But what would be more critical than that? If you have smaller vessels, what is it you do not want to happen in those small vessels?
Clot.
You don't want a clot to form. So what lab value tells you about clots? Not
PT.
Not that one.
PT.
Not that one. It's another P.
Platelet clowns.
Platelets. Hey, you was getting there. That's all. So, you know, when platelet counts are extremely low, then we need to be worried about what? Clots?
Clots.
Okay. So if it's, you know, in the 20,000s, if it's 40,000, 30,000, then that's super low. And usually when it gets that low, there's a lot of in-organ damage because of that lack of blood flow related to the vasoconstriction. I was like, what is that word? That was driving me bonkers. Okay, so what medicine do we give them if they have eclampsia?
Magnesium.
Magnesium. So now the question of the day is, if you're given a magnesium, how do you know when you should discontinue it? What signs and symptoms would you see?
When the deep tender is absent.
Okay, so absent deep tendon reflexes. What else? What would the respiratory rate be?
Slower.
Slower, okay. What else?
would their blood pressure go down?
Not necessarily. I mean, it depends on how high it was before, so we need some more additional numbers related to that. But
Mhm.
usually a big telltale sign is having an absence of the deep tendon reflexes. And they're like really thirsty and they feel warm. So then we stop the magnesium at that time?
Yes.
Absolutely. What would we give them as an antidote?
Calcium.
Calcium gluconate.
Calcium gluconate would be what we would give them to help facilitate that. So if your patient say that they can put a heating pad on their leg and they have peripheral artery disease, would that be appropriate?
No.
Absolutely not. So if they need to keep their feet warm, they need to put some socks on, not put on a heating pad. Why? Why not the heating pad?
Skin burns.
Because the skin burns. We already have decreased perfusion and sensation. So if we put heat on it, then we can end up now causing a second-degree burn. So we don't want to do anything of that nature. So.
I do have a quick question. Why, for artery diseases, we do not put TED hoses or constrictive clothing, but for venous we do?
Because we're trying to improve the blood flow. We have a clot, so we don't want to squeeze that clot and have it dislodge. Now, if the patient has heart failure, you can, like excess volume, only under those conditions. It's only one condition where you can do that with arterial. Other than that,
Okay.
Okay. But that's a very, very, very good question. So I like that you asked that. If you have high blood pressure, will you automatically, can you just stop it cold turkey?
You're not supposed to.
Okay. So the design of the medication is to make the patient's blood pressure more normal, correct? So if your client basically says, you know what, I'm gonna take this medication until my blood pressure is normal, then I'm gonna stop. We need to discourage that and, start talking about compliance and the importance thereof, because they're kind of out there. They're not thinking clearly.
We can educate them. The reason you're feeling better is because you're taking your blood pressure medicine.
Exactly. And that's the piece that they miss, because they're like, oh, I feel so great. And that's like, oh, let me stop. But grown people do that even when they do not have those kind of conditions, but they do it anyway. And the reason why is because they don't want to go, if it was a lot of drama to get the pills in the first place, and they're going to try to squirrel some away. But what you do is make yourself more vulnerable to developing resistance to the medicine or sensitivity where it doesn't work as well. So then you have to require something different. Somebody's phone beeping or text message.
No.
Because you have me, every time I hear bong, I'm looking at my phone. I'm like, is that me? All right. Let's see where else I want to go. I think that was all of the hypertension, coronary artery disease stuff that we needed to cover, or not necessarily needed to cover, but I wanted to kind of revisit briefly.
So on pregnancy-induced hypertension, we do not have to know the Naegele's calendar.
No. You will know. Now, when you get to third, you will calculate Naegele's rule. You will use Naegele's rule to calculate the due date. Let me say it that way.
Okay.
But
Yeah,
the Naegele's rule was just kind of, when a check for you. These are just things that you can do to be that better, prudent nurse to kind of figure out what's going on with your folks. But
okay.
no, Naegele's rule is not on there. So I know people are going to say, whew, Lord. All right. So I think that was all of the coronary artery disease stuff. So we can start talking about a little bit of GI. We can do that.
Sounds good to me.
All right, so if your patient has diverticulitis, what signs and symptoms would you anticipate the patient displaying?
Right lower quadrant pain, tenderness.
Right or left?
Right.
Left. It's left lower quadrant pain.
It's left because usually diverticulitis is in the sigmoid colon, which is on the left side of the body, right?
I'm looking in the mirror, sorry.
Okay. Because I'm looking in the mirror, I'm sorry. Okay, so what else? What other signs and symptoms are common for diverticulitis? Would their bowels be regular?
No.
Would they have periods of diarrhea?
Yes.
Yes.
No, they should be wouldn't they be constipated?
They can have diarrhea.
They can have diarrhea. And it's not like it's constant diarrhea, but intervals because things are trying to get by. Would they have a low-grade fever?
Yes.
Yeah, they can have a low-grade fever.
And cramping, right? You said.
Cramping, yep. That would be something that they can develop. So if they have Osis Diverticulosis, what is the Osis part? That's the condition of having diverticula. And what is a diverticula?
It's a little pouch in the intestine.
It's the outpouchings. So what types of things, what are risk factors for those outpouches?
Stress.
Okay.
Processed foods.
Okay, so is stress active? Is that like an active lifestyle, or is an active lifestyle like up and moving around and exercising and all of that?
Is what now?
I said, is stress considered an active lifestyle, or is stress when you're up and you're moving about, your life is really busy, you're exercising, you're kind of on the go?
No, the first one.
It's the second one.
That was the second one.
Yeah, active lifestyle means you're not sedentary. So you may engage in intramural sports, or you're staying active. But stress is something completely different. So besides stress, what else?
Elderly.
Okay, besides elderly.
Low fiber diet.
Low fiber diet. Okay, so history, if you have a low fiber diet, then you're going to be what also?
Eating a lot of processed foods.
Okay, so eating processed foods, but if you have a low fiber diet, then you're not going to be pooing regularly, correct?
Constipation.
So they'll have constipation. So advanced stage, we talked about that. What about obesity? Would that fall in there as well?
Yes.
Yes. Smoking.
Absolutely. So those things would be contributing factors to an individual developing diverticulosis. And then the itis is when they actually have a inflammatory process of some sort that's brewing or has brewed. Okay. What would be a concern? So you have 4 patients and you need to determine who you're going to assess first. So this is like priority. So let's rank these. So you have a patient that cannot void after they've had an inguinal surgery. You had a patient that had kidney stones, but they passed it. They think they did. You have a patient that doesn't want to get up out of bed or ambulate after they've had like a biopsy. Or a patient that's had a hard abdomen. So who should you see first?
The hard abdomen, I think.
The rigid abdomen would be correct. You would definitely need to see that person. Some of the others, they par for the course based on what they have. Let's see what else I want to tell you. Or at least address. Well, I think I covered that piece too. All right, so let's talk about the bladder while we're here. What's the most common cause of a neurogenic bladder?
Head trauma. You
Okay. What else?
spinal cord injury.
STI,
What was that, Nico?
STI, spinal cord injury.
Oh, he said that. I was like, what?
I
I
thought
was
we were
like, what
watching.
eye?
I thought we were watching the cop show NCI.
Well, MCI is that mass casualty incident. That's exactly what I thought she said. I was like, but no, not that one. So what if they, okay, so you have a patient, they have a neurogenic bladder, they now have a fever, they have dysuria, they have suprapubic pain. What do you think their issue is?
Fluid retention in their bladder.
Okay, it is fluid retention, but what's going on with that fluid that's in there if they have a fever?
They got some infection.
So if you have an infection in your bladder, what is that called?
Stagnant bladder or stagnant urine.
An
No.
infection in your bladder, what is that called?
UTI.
A UTI.
Oh,
You guys are overthinking. I was like, it's an infection in your bladder, period, which is basically cystitis is what they call it, but it's really a UTI. And UTIs can be in the urethra, it can be in the kidneys, so that bacteria can definitely flow upward if things are not taken care of. But yeah, I was just like, I'm not trying to trip you up, I promise. It's just more of what is an infection in the bladder. Let's see. We did GI, we did GU, hypertension. We covered MAG, we covered all of that. We did heart failure. We talked about labs. We talked about the basic ECGs.
Mm-hmm.
So I think we got all of that covered. Okay. So tell me the two types of hearing loss you can have. Sensory and what?
Conductive.
Conductive, right? So you can have one that's nerve, and then you can have one where you have like a bunch of earwax. What color is earwax?
Yellowish.
So it's kind of like a yellow to brown color. Could it ever be black in color?
If it's bloody, I guess.
I'm sorry?
If it has like blood in it or something, old blood.
It could just be old earwax that's been sitting in there for a long time.
Ugh.
So, some people have an earwax. The other word is what? What's the other word for earwax?
Cerumen.
Cerumen. So you can have cerumen buildup, and some people produce a lot of it very, very quickly. And, they don't clean their ears. Should you clean with a Q-tip?
No.
No.
No, you really shouldn't. You should use like a baby bath rag to actually clean your ears with. But, so say, for instance, you're doing an ear exam and you see this dark yellow substance over the ear, then what can you do to help the person hear better? Especially if they're complaining that they can't hear. What can we do?
Clean their ears for them.
Or irrigate the ear. So you can do like an ear irrigation to remove the wax buildup. So I remember, I had a client they could hear, but it sounded kind of muffled. And so when I looked in their ear, I saw this black thing. I actually thought the ear was scarred. I was like, this is some strangeness. And I said, well, let me just irrigate the ear. And then the earwax just came out, but it was just black. It had been sitting in there and hard.
That's just gross.
It is gross, but that's just what that's what it be. Earwax, well, I guess, wasn't designed to be sexy.
I clean my ears way too much, my doctor says. It's a habit I have. I don't know why.
But some people do. I notice when I use my earbuds, for some reason, I have more earwax buildup than if I don't wear my earbuds. So I can't explain it. I just know that's what I experienced. So, everybody has a different experience related to that. What is the normal hearing loss that happens in elderly people? What is that word called? So as your clients get older, then what is that word?
Deaf.
No. It's a normal process of aging, honestly.
Selective hearing.
No, selective hearing means you choose not to hear. So that's basically, it's a person who is basically ignoring you, but they're pretending they don't hear you. Oh, I didn't hear you, but you're standing right next to them and they were looking right at you when you said so. You guys are going to be like, oh my God.
Hearing loss.
You all know this. Trust me. This is a sensory neural hearing loss, and it's just caused by aging. What is that word?
I feel like I'm overthinking.
You guys are hurting me here. Okay, it starts with a P. Presbycusis.
I never heard that word in my life.
Seriously?
I've never.
Yes, that's how you know people are, that's a normal part of aging, is that they'll start, what did you say? What did you say? So they'll do like that, or turn their head so that, the ear is on the side where the voice is coming from. But it's just a normal process of aging. It's a sensory neural loss.
And how
So
do you get presbycusis?
presbycusis, yep, presbycusis. And so here, it affects how they hear high-pitched sounds. So people, remember we talked about this in the summertime?
I have Alzheimer's.
Oh my goodness.
I forget.
It was that whole it was like somebody was hearing one thing and I hear low pitch, and some people the Yanny Laurel thing.
Right, but see, when the normal process of aging is you're going to have hearing loss, hands down. The point being is, how do you know it's happening? So most people do like this, or they'll turn their head so that the ear that they can hear the best with, they can get what you're saying. But the normal process of having this hearing deficit is because they have what they call presbycusis, which is basically natural aging of the auditory system. So that's normal. But when you have like Meniere's disease, is that like a normal process of aging?
No.
No, that's completely different.
So Meniere's is a hearing issue. I thought it was like a balance, or is it both?
It's both, because I think it's their equilibrium with their inner ear, right?
Correct. So because we have different pieces or not different pieces, but different section of the ear.
Right.
So you can have an equilibrium issue, even just from sinus. So that eustachian tube is kind of out of whack.
That's true.
So yeah. But what is Meniere's? It's actually in the inner ear. It's an inner ear disorder.
Mm-hmm.
So yes, but yes, they will have difficulty with their balance, and they may actually, would that be a fall risk?
Yes.
So should they be walking by themselves?
No.
Absolutely not. So we don't want them walking by themselves. What else do we want to do?
Educate them. They could be dizzy.
Mm-hmm. And then we want to see how bad this is, or, is this going to get worse? Because it can be in one ear and then move over to the other ear. Right. If they have infections or smoking or a high salt diet, then this can actually make this disease worse. So we want to monitor that hearing loss to see, how quickly the hearing loss is happening. versus just kind of ignoring it per se. What about hearing? What about hearing in infants? How do you know an infant can't hear?
They do testing.
They do. Okay. I don't want to use like two do's together because it sounds like doo doo. But they do hearing test on newborns and things like that. But usually their initial sounds is the first step in language development. So that's the reason why they do the hearing test. And it's almost as if you're talking to the baby, because if you're usually when baby hear noise, what do? If they hear it over here, they turn here. If they hear it over here, they turn here. So if you're talking and the baby's just like this, that's a problem. Does that make sense? So if you're talking over here and the baby doesn't turn to the voice or anything like that, then that may be, the baby may have some hearing deficits. But we really want to see if they do, because if you can't hear the sound, then how can you actually, speak the language?
Like Nell.
So yes, just kind of think about that. What's her name? Jodie Foster, when she was out there in the wilderness.
Swaying in the wind.
I was like, did he say Nell? I was like, that's a old movie, an old movie. Okay, so how long should a newborn sleep for?
16.
Not long enough.
14 to 20 hours.
So 14 to 20 hours. So if you waken if the baby's up every 2 hours, whose fault is that?
The mom's.
Absolutely. So yeah, I can't remember if I talked about that in you all's class, but somebody was asking me about that, and I remember saying, it amazes me when people are like, the baby was up all night. I said, the baby was up all night because that's what you train the baby to do. I said, let the baby sleep. They'll let you know when they want to be fed and and everything else. Just leave them be. But you're picking them up. I'm like, oh my God, he's so cute. Oh my gosh, he's so cute. And the baby's like, I can't sleep. All right. So if people are having sleep issues, what's usually one of the first signs of depression related to elderly people who can't sleep? If you can't sleep, then what are you doing? And not necessarily, not like you're reading. That's not what I mean. So if you're up all night, what is that word known as?
Insomnia.
Insomnia. Sleep, believe it or not, they're starting to look at sleep, and I think I shared this with you guys, as being a cause of a lot of the cardiometabolic issues that we have: diabetes, high blood pressure, heart disease. This is actually starting to get really, really serious. So, I mean, they've had several sleep experts talk about at least getting 7 hours of sleep. And, if you sleep too much, then your body doesn't respond to it as well. So all of those. Give me some signs and symptoms of sleep apnea, since we're talking about sleep.
Snoring.
Okay.
Stop breathing at nighttime.
That's definitely a problem.
Obese.
Okay. Do they have any behavioral issues or emotional issues?
Isn't it drinking? Can alcohol is snore?
Depression.
Oh, okay. What about drinking?
I don't know. I just know my dad snores more when he drinks.
Well, his tongue is more relaxed because drinking is a central nervous system, what? Accelerant or depressant? That's a depressant. So sleep apnea, when you have obstructive sleep apnea, they are going to snore very loud. They could, have dysrhythmias because of, that could lead to heart failure, because there is a loss of blood oxygen levels when we have sleep apnea for people who have OSA, the obstructive sleep apnea. Because if you don't get a good night's sleep, how is your demeanor? And this is what I would do. They have behavioral issues, and they do. But how is your demeanor the next day?
Frankie.
You're irritable. You're just, every small little things that you would not necessarily address on a regular basis. It's like all of a sudden you become laser focused on that, and it becomes like your vice for the day, your soapbox. They may actually fall asleep, during the day or during an activity, have difficulty concentrating, slower reaction times, and more likely to have a car accident because of it. So their performance at work, would it be high or low?
Low.
It's going to be low. So even if they were in school, their activity level is just not going to be up to par. So those are some, huge concerns when it comes to lack of sleep. And, usually most elderly, they'd be up all day and all night long. And you're just like, holy cow, let's help these poor people. Let's see, what about, going through my notes here, because I had some things that I had marked that I want to review. I think that may be it on the sleep. Yeah, I think that may be it on the sleep. All right, BPH, what is that? B as in boy, P as in Paul, H as in Henry.
That's that prostate, where it's an enlarged prostate.
It is an enlarged prostate. So what signs and symptoms would you see related to that?
Struggling urine, like they're struggling to pass urine.
So,
Urine
okay, so
retention.
there's difficulty with the urinary flow. That's what you're saying?
Yes, ma'am. Sorry.
Oh, okay. So they feel like they got to go. So there's urgency to go, but then it's like there's some hesitancy for the flow to actually dispel out. Do they have pain with urination?
Yes, because of their bladder. Well, not like in their actual like penis tube, but like their bladder hurts, I guess, because it's full of urine that they can't get it out. So it's like almost like spasming.
Okay. And are they up all night with this?
Yes.
Yes. I asked one of my neighbor's dog, he had some type of bladder infection, poor thing. He must have hiked up his leg. If he didn't do it 100 times, he did it 200 times. And there was nothing coming out. And I know he had to be super frustrated. I was like, that would just drive me nuts if I had to sit there and couldn't pee. And he was like, well, I guess, he can't pee, so all right. I was like, hello, take him to the vet. Okay, so since we're talking about pee anyway, I'm gonna go back to that BPH. I'm going back to the neurogenic bladder because I just thought of something. So when you have a patient with neurogenic bladder, what type of training should they do? What kind
Kegel.
of teaching?
Bladder training.
Okay, be
Kegel.
specific.
Kegels.
Kegel exercises to strengthen the pelvic floor. Yep. What else? And these are things that we talked about right at the end of lecture. Some would require intermittent catheterization, so you want to put them on a schedule, like every 2 hours. We're going to talk about that, kind of like potty training. Should they?
How is that an exercise?
I didn't say exercise. I said what type of training would you give them? So more training meaning education. So basically, what would your teaching plan be?
Not to eat a lot of watery fruit and vegetables.
Okay, so
No
what's the max?
watermelon.
What's the max they should have with every meal?
Every meal?
400 to 500 ml.
400 to 500. Should they have caffeine and spicy foods?
No.
What medications should we give them?
No.
It is ditropan, but you're going to have to know the other word for ditropan, which is oxybutynin. So oxybutynin or toltolerdine. TOLTERODINE. but that's the detrol. So intermittent cath, Kegels, medication, so oxybutynin, excuse me, and then only 400 to 500 of liquid per meal with each meal. So 2,000 every 24 hours is what they should be doing. What if they have a Foley?
An
How
indwelling
much fluid should they take in then?
per,
About
minute,
3 to 4 liters is what they should do
per day or meal?
per day. All right, so you have a patient that just came out of surgery. What concern would you have in relation to the abdominal area?
Paralytic Ileus.
A paralytic ileus. Okay, so how would you know? You know, what should you do what should you do? What would be a management of a paralytic ileus? What would be the first thing you do?
NG,
For balance sounds.
Oscillate bowel sound.
What else?
NPU and NG2.
Insert an NG tube and make sure that the NG tube is patent. So if they already have an NG tube, because usually when most people come back from belly surgery specifically, they'll have an NG tube in. So we want to make sure that it's patent and that it's working. Why do we do the self-catheterizations? Why do we do that for neurogenic bladder? Why do we do it?
Prevent bladder extension.
What about
PIs?
prevent the bladder infection? So that would be one. It gives them more independence. And so if you're more independent, how's your self-esteem?
Better.
It's improved. So that's the other reason why we want to, kind of focus on that. There was something else that I saw on my notes to remind myself. Excuse me. I'm having some sleep deprivation right now. You guys like me too. I think I kind of got most of my questions through, even if I had to go back and backtrack. Yep. I did. We talked about ears. Glaucoma. I knew it was something else. What types of people are at risk of glaucoma?
Elderly.
Okay. What about diabetics?
Yes.
Okay.
And smokers.
Hypertension.
Okay. What about family history?
Yep.
How about corticosteroids?
Yeah.
Okay. So those are things that keep in mind. Cataracts. What are some complications of cataract surgery?
Blurred vision.
Okay. So infection, pain. What if blood just started coming out the eye? Would that be normal?
No.
Exactly. That would not be normal. So if you have a patient that is having difficulty sleeping, what could be some things you could do? So they're telling you that they're having difficulty sleeping. What would be the next thing you would do based on the nursing process?
A sleep assessment.
Ask them.
What their sleeping pattern is.
Ask them what their sleeping pattern is. When do you normally go to bed? What do you do to wind down so that way your body knows, okay, this is turn down time and we need to start resting. So those are things you want to, kind of identify. All right, I'm gonna bounce back to cataracts. What kind of medications do they get after surgery?
Eye drops.
What kind?
Uh,
I know they're eye drops.
antibiotic eye drops.
Antibiotic eye drops. Okay, I like that. You're getting there. Okay. Do they have any pain eye drops too? Pain relief?
Yes.
Yes. So there's a couple of them. So we covered eyes, ears, GI, GU.
Eye injuries. Eye injuries.
Yep, eye injuries. So, if you have somebody with an eye injury, do you want to try and get to see how much they can see?
Yes.
Yeah. I mean, without straining,
Oh, yeah.
So we want to see how much they, what they can see, what they cannot see. So how is math going for you guys?
I'm doing real good.
How about everybody else?
Okay.
Okay. Do you need?
Are we gonna have a lot of questions on this test for math?
No more than what you've already had. Probably about five questions.
Okay.
So somewhere in there, 4 to 5 questions. Nope, it'll be about 5. So, I mean, remember to look at your units and, make sure you know how to move from one set of units to another don't change the doctor's orders, but change how the bag or the medication is supplied. You can do that.
Did we talk about C. diff?
I did not talk about C. diff because I covered that one in class. So I thought you guys were kind of good on that one. I think I think I pulled you guys out.
Yes, you did.
So that was one. I was like, I think I hit that one pretty good. So didn't want to jack that up anymore. So, all right. So you guys have any additional questions?
No, 60 questions, an hour and a half.
60 questions. I think you get how much time do you get normally now for your test? Before they did the 60 questions.
I don't know. I thought
Well,
last test.
it's the same as the last time because I think you guys did 50, 50, 60, 60, correct?
Yeah.
Yeah, it'd be the same as exam 3. So nothing different. So, all right, if you guys don't have any additional questions, nothing burning through your brain.
Will you post this on Zoom?
Yes. So I'll be up for a little bit and wait for this to download. I know last couple of Zooms, it took like forever. I was like, what the heck is going on? So I'll post this up tonight and try so that way you'll have it before the weekend kicks in. And since it's raining anyway, it look like you'll have more time to look at it.
Thank you so much.
All right, guys. All right. So other than that, we'll see you on Monday.
Thank you.
You're welcome. All right.
Thanks.
Good night.
Bye. Good night.